Good morning, everyone. My name is Brad Denker, and in the next 30 minutes or so, I'm going to review with you some of the basic principles of sodium and potassium physiology. This is to provide a framework for you to approach clinical problems, many of which are summarized in one of the upcoming question and answer sessions. So what we'll do in the next 30 minutes is review the basics of sodium and potassium disorders, as these are the most common ones encountered in our clinical practice. So sodium, it's best to think about the sodium that we measure in the blood literally as the concentration, the amount of sodium divided by the amount of water. And by doing it this way, we can approach it physiologically because these are regulated by two different hormone systems, the renin-angiotensin system, which controls volume, and the ADH system, which controls tonicity or water. These systems do cross over, which is where much of the confusion in approaching patients arises. And I hope to clarify that with you as we go through these slides. It's also important to remind you that osmolality in the plasma is proportional to 2 times the sodium. But what we're really talking about are the total positive charges, the sodium and potassium. But it's because the intracellular potassium concentration is so high, it balances the extracellular sodium. So these two ions are essentially reciprocal in their concentration, maintained by the sodium-potassium ATPase. So let's go to hypernatremia. Coming back to our concept of the amount of sodium divided by the amount of water, I can think of 2 ways in which we can end up with an elevated sodium concentration. One would be to pour more salt into the system, our bodies, or the beaker. And this happens, but it's pretty rare. More commonly, there's a loss of water, which leads to that elevated sodium concentration. So if we're talking about water losses, then we want to consider whether these are happening through a renal mechanism or through other sources, such as the GI tract. So when approaching a patient with hypernatremia, it's useful to start with the urine osmolality, measured in milliosms per kilo, as this will provide a framework for approaching patients with an elevated sodium concentration. We can divide it into 3 broad categories: low osmolality, intermediate, and high. High osmolality is usually associated with relative oliguria, not a normal urine output or high urine output as you might see in the other conditions. And these are most commonly seen with insensible losses and or GI losses. But most of us would get thirsty and drink, so there's often an impaired ability to take in water to help neutralize or counteract that hyperosmolality. And then rarely sodium intoxication. Again, the concentration being the sodium divided by the amount of water. This is a rare condition. Sometimes people will try to commit suicide by overdosing on salt. And occasionally infants will be given an inappropriate formula, but basically sodium intoxication is pretty rare. Now we come to the intermediate and low osmolalities where there's renal water loss. And if the urine osmolality is less than 300, we want to consider diabetes insipidus, either central or nephrogenic. And then the intermediate types, which are often an osmotic diuresis seen in inpatients due to elevated blood glucose, get perhaps in the outpatient setting with a new diabetic. Urea can be seen with hyperalimentation. Mannitol may be administered for other neurosurgical or other medical reasons. So when approaching a patient with nephrogenic DI, this is a broad differential that we'll just touch on quickly: hypokalemia, chronic, hypercalcemia, chronic, a variety of tubular interstitial diseases, including sickle cell, multiple myeloma, obstructive uropathy, recovery from ATN, or the most common one in the outpatient setting would be chronic lithium use. And then, of course, chronic renal failure can also lead to this condition as well. A very simple approach to distinguishing central versus nephrogenic is to deprive someone of water, watch their sodium and their osmolality in the blood rise, administer arginine vasopressin, and if they're deficient in that, they will appropriately concentrate their urine. But if they have a nephrogenic cause, such as with lithium, there'll be little or no response. And this is how one can approach distinguishing central versus nephrogenic DI. In terms of managing correction, we were all classically taught in medical school that we should replace no more than 50% of the deficit in the first 24 hours, and to try to go less than a half a millimole or milliequivalent of sodium per hour. This is the formula for calculating the water deficit. A relatively recent paper published last year, however, showed that in about 450 ICU patients who were corrected with varying degrees and rates, there was really no difference in clinical outcomes such as mortality, cerebral edema, or seizures, even in those who were corrected more quickly. So unlike hyponatremia, where the rate of correction is really very important, it may be a little less important for managing hypernatremia. And of course, you want to calculate and replace those ongoing free water losses. So if you're treating a patient with hypernatremia, you want to try to treat the underlying cause, why they're not drinking. Figure out central versus nephrogenic DI. Central, you can give vasopressin. Nephrogenic DI is more problematic to treat. There may be some partial activity of exogenously administered vasopressin. Many patients are on lithium and are unable to stop the drug for a variety of reasons. And even if they do, the nephrogenic DI may not improve. And there's a few tricks that you can use to reduce the urine volume for those patients who are bothered by it, by decreasing the amount of solute, because our urine output is proportional to our solute excretion, or by imposing a little intravascular volume depletion with a thiazide, you can reduce the urine volume. Any of these done in a patient on lithium do require monitoring of the lithium levels, however. Okay, hyponatremia, the most common electrolyte disorder that we face in clinical medicine. And coming back to our approach of looking at it in the amount of sodium divided by the amount of water, I can come up with three mechanisms where you may become hyponatremic. One would be to have an absolute deficiency of sodium in the setting of a constant amount of water. One would be to have a constant amount of sodium or an increased amount of water, or a combination of these two. Now, remember, sodium is the major extracellular osm and really determines our volume status. And remember that sodium is regulated by the renin-angiotensin system, whereas water is regulated by ADH and is commonly seen in euvolemic patients to be in excess of water or a hyponatremic state. And then a whole variety of acquired disorders where people will become volume depleted from a GI cause or other reasons. And of course, when we drink, we tend to replete with hypotonic fluid. So you end up in a situation where you're both a little sodium depleted, but you've replaced with additional water. And again, by way of reminder, these are independently regulated systems and should be thought about independently. So when approaching a patient with hyponatremia, do not be fooled, because not all hyponatremia is hypoosmolar. There are a variety of conditions where it's a physiologic reduction in the sodium concentration due to very high glucose levels in the serum, or perhaps mannitol excretion. Two artifacts of the way sodium is measured on a Chem7, high lipids or high protein, or indeed a hypoosmolar hyponatremic condition, which requires ADH secretion and water intake in order to become hyponatremic. And this, of course, is the most common clinical scenario that we're confronted with. And once we've confirmed hypoosmolality, it is really very useful to think about your patient in terms of their volume status. We can have hypovolemic, euvolemic, or edematous conditions of hypoosmolar hyponatremia. Hypovolemic conditions are usually obvious from the clinical presentation, but can be seen in this endocrine disorder of adrenal insufficiency or Addison's disease, or of course through the use of diuretics. Edematous conditions, where we have a hypoosmol or hyponatremia, are seen in conditions of an underfilled arterial circulation. So these are the pathologic conditions where there's decreased perfusion to the kidneys and other organs due to either heart failure or liver failure. And this will stimulate ADH as a volume compensatory mechanism at the sacrifice of osmolality. And I'll show you that on a subsequent slide. Euvolemic hyponatremia, we'll talk about in a moment. These that are starred are characterized by activation of the renin-angiotensin system. And the hallmark of that is a low urine sodium. Again, urine sodium is determined by the renin-angiotensin system activation, whereas the osmolality will be determined by ADH activity. Euvolemic patients, we're often trying to distinguish between too much drinking or too much ADH. And also on the list to exclude is another endocrine disorder of hypothyroidism. This is highlighted in green because these are easy to distinguish: psychogenic polydipsia versus SIADH, where by definition the urine osmolality is inappropriately elevated for that degree of serum osmolality, whereas folks that are drinking too much, there's nothing wrong with their ADH axis. It's turned off and they put out a dilute urine as shown there. This just highlights the physiology of ADH stimulation, both an osmotic stimulus with a change of 5 to 10 to 15%. You can see the increase in ADH, but also some volume depletion. And this is both the underfilled arterial circulation conditions, as well as prolonged true volume depletion from any source. So in this situation, osmolality will be sacrificed in order to try to preserve circulating volume. And it's when these cross that folks are often a little misled in terms of interpreting the hyponatremia. So how do you treat hyponatremia? Well, if you're hypovolemic, it's straightforward. Give isotonic saline. If someone's drinking too much, they might need a psych consult, but restricting their water will correct that. And if you're dealing with SIADH, we use a combination of approaches, including water restriction as an underpinning, and then a variety of approaches that can help the kidneys excrete more water, which includes giving hypertonic saline or sodium tablets, further diluting the urine with furosemide. And although not widely used clinically, we do have an antagonist to ADH, which are the vaptans, and they do work at raising the serum sodium. But I've only used them a few times in the setting of SIADH due to side effects and due to cost. Again, the rate of correction is important. If the development of the hyponatremia has been acute, you can correct it quickly. A nice rule of thumb is to remember that 100 mils of 3% saline will increase the serum sodium by about 2 to 3 milliequivalents. So this can be done in someone who's seizing or in a severely symptomatic patient. This is what's also done at events like the marathon, where hyponatremia is occasionally seen. If it's a chronic condition, you want to be much more careful about precipitating the complications of too rapid a correction, no more than 0.5 milliequivalent per hour, and no more than 6 to 8 milliequivalents in the first day. For patients at high risk of central pontine myelinolysis or osmotic demyelination syndrome, such as an alcoholic, you may even want to correct only from 4 to 6 in the first day, which is a very slight correction. So this is the big fear of correcting too quickly, central and extrapontine myelinolysis. An excessive rate of correction is certainly a risk factor. A nice review of this published in C. Jason a couple of years ago now showed that in the handful of cases that he analyzed, if the rate of correction was less than 12 within 24 hours and less than 18 in 48 hours, there were no cases of CPM. However, this is a small study and one still needs to be very careful. The classic condition presents with this dysphagia, quadriparesis, and locked-in syndrome, and it can be permanent or fatal. So quick question, quick board question. A 26-year-old, otherwise healthy male presents with a seizure. The serum sodium is 115. The rest of the electrolytes are unremarkable. Urine sodium is 30, and the osmolality is 45. What's the most likely diagnosis? Give folks a chance to pick. Well, the two people that voted definitely got it right. So far, that's great. Well, for the sake of time, I'm going to move on. Maybe I didn't give folks quite enough time, but let me. So it's pretty much breaking down between the two that I would predicted. And the clue here is the urine osmolality being low. So I think if I click the next slide. So psychogenic polydipsia is the correct answer. And the reason is, if you look at this approach, this patient falls into euvolemic, and I can define that by the urine sodium being 30 or greater. And the low urine osm tells me that that's the condition we're dealing with this patient. All right, so let's move on and take the last 10 or so minutes to talk about potassium disorders. So I just want to remind folks that, again, most potassium is intracellular. It's essentially the opposite of our extracellular sodium concentration, and that the total potassium in the body is quite high at 4,000 milliequivalents. Whereas in the extracellular space, what we measure in the plasma, if you take an average sized person with 14 liters of essential extracellular volume, at any one time, there's really only 70 milliequivalents of potassium in that extracellular space, with most of it being in cells. And that's important to keep in mind because we consume about 75 milliequivalents per day. So if we didn't have a mechanism for rapidly redistributing this potassium intake, our serum potassium concentrations would rise dramatically with every time we ingested some potassium. So we're going to move on to the hyperkalemia. As with all lab samples, be careful of hemolyzed blood or a true leukocytosis, thrombocytosis. We want to check an EKG and the whole blood potassium. And when approaching a patient with hyperkalemia, we want to think about what's coming in and what's going out. Intake, we do have some control over. The kidneys are the main organ, of course, for excreting potassium. And then there's that huge intracellular reservoir that potassium can be taken up inside cells. And that will be made worse or exacerbated by things like a metabolic acidosis, where by buffering hydrogen ions in the cell, potassium is going to come out. And anything that blocks the uptake of potassium, such as digitalis or beta blockers, will also lead to worsening hyperkalemia. So when I think about urinary excretion, I'm really talking about two broad mechanisms. One is how much kidney function do I have? Because folks with reduced GFR are going to have impaired ability to get rid of everything, including potassium. And then there's the hormones that regulate potassium excretion in the collecting duct. And that's shown here that I'll go through quickly, where aldosterone is the main regulator binding to its receptor, stimulating the insertion and opening of these epithelial sodium channels called ENaC. The absorption of sodium without chloride generates a lumen-negative potential, which promotes potassium excretion. And the reason I show this is that we have a lot of drugs that affect these different pathways. So again, decreased renal mass, adrenal insufficiency, of course, or hyporenin hypoaldosteronism. And then the meds that can affect various aspects of that slide that I just showed you include nonsteroidals, ACE inhibitors, heparin, spironolactone, cyclosporin, and then a variety of drugs that directly interfere with that epithelial apical sodium channel. Brief word about hyporenin hypoaldo. This is so-called type 4 RTA. We'll touch again on this in the second talk. It's the only RTA that's associated with hyperkalemia. It's a non-metabolic acidosis, often seen with mild chronic kidney disease or underlying tubular interstitial diseases. I won't go into this in detail. Most of you are comfortable with the acute treatment of hyperkalemia, including stabilizing the membrane, pushing potassium back into cells by giving glucose and insulin. This is to prevent hypoglycemia. This is what drives it into the cells. Beta agonist, bicarbonate, but ultimately you have to remove the extra potassium either by binding it in the gut, getting the kidneys to excrete it through increased use of diuretics, or in patients that are in life-threatening danger, perhaps dialysis. Okay, in the final few minutes, we're going to talk about hypokalemia. And here, it's similar in that the cellular shift is the opposite to what we saw with hyperkalemia. And this will be enhanced by alkalemia, where potassium will be taken up by cells, insulin, beta agonists, a rare condition called hypokalemic periodic paralysis that we'll mention briefly for the sake of board review. Then there are GI causes and renal or urinary wasting causes, but we'll come to those after a brief side track to hypokalemic periodic paralysis, a favorite board's question. Typically a positive family history, more common in Asians with a history of thyrotoxicosis, precipitated by meal or exercise, repetitive episodes of acute hypo and profound hypokalemia, recovers pretty quickly, and the urine potassium is appropriately low because it's not being wasted in the urine, it's going intracellularly. The GI causes are vomiting and diarrhea. With diarrhea, it's direct. There's potassium losses in the stool. But with vomiting, it's indirect because of the alkalosis that is induced. And then diuretics or hereditary disorders affecting some of the transporters can lead to elevated urinary K wasting with a couple of different definitions that are defined here for you. So again, the vomiting ends up to be more of a urinary K wasting because of the alkalosis. Now, when confronted with a patient with hypokalemia, renal potassium wasting, and hypertension, we think about disorders of the renin-angiotensin system. And I've shown for you here the pathway from renin substrate to aldosterone, where renin, the enzyme, converts renin substrate to angiotensin 1. Of course, you'll see elevation of that with any hypoperfusion condition. Converting enzyme, we have lots of drugs, ACE inhibitors that work here. And then aldosterone, its major physiologic effect is to promote sodium absorption. That's why it causes hypertension and hypokalemia as one of the hallmarks of that condition. The rough workup of someone with hypokalemia, renal K wasting would be to measure the renin and aldo levels. Primary aldosteronism will be associated with a high aldo and a low renin because of appropriate feedback. High renin, high aldo seen with renal artery stenosis, or a very rare condition called a reninoma. And then a variety of things that mimic this but don't elevate aldosterone, such as activating mutations in that epithelial sodium channel, Cushing's syndrome, and other disorders that affect cortisol metabolism. This is that pathway that I showed you previously, where normally a high aldo will suppress renin. And if you have exogenous aldo production, you will see that with primary hyperaldosteronism. What about low potassium and normal or low blood pressure? Well, here there's a variety of conditions: osmotic diuresis, drugs, vomiting, renal tubular acidosis, and inherited tubulopathies. These are the two most common ones that mimic each other, one through the use of drugs, and then the hereditary disorder that correlates with mutations in each of those transporters. Barter's for the loop diuretics and Gittleman's for the distal tubule thiazide diuretics. So in the setting of a metabolic alkalosis, the urine chloride is actually a better marker than the urine sodium. And that's because of the filtered bicarbonate, which is negatively charged and requires a positive ion to go out in the urine with it. And we only have two in the urine that we can use, and those are sodium and potassium. So the urine sodium may be elevated, but the urine chloride will be low in the setting of hypovolemia due to extrarenal GI causes. If the urine chloride is high, it suggests renal salt wasting, such as with Barter's, Gittleman's, or the use of a diuretic. This little table nicely summarizes these: unexplained hypokalemic metabolic alkalosis, hyperaldo, surreptitious vomiting, diuretics, and Barter's-Gittleman. Hyperaldo is easy because it's the only one associated with elevated blood pressure. And here, the urine chloride is the most helpful. To distinguish these two, which look identical physiologically, you would need a diuretic screen in the right setting to distinguish amongst them. All right, quick question, and we're almost done. This is a 75-year-old male with known coronary and peripheral vascular disease who presents with worsening hypertension despite treatment with HCTZ, amlodipine, and candesartan. Which diagnostic test is most likely to be useful? I'll give you 15 or 20 seconds, and I'll pause. All right, we'll give it another second or so. I want to try to keep us on time for Dr. Singh, who's already appeared. All right, well, why don't we sort of cut it off there? It looks like most people have the correct answer of a Doppler ultrasound. Some people thinking maybe a primary hyperaldo or a diuretic screen. So let me see. So the correct answer here is a Doppler ultrasound of the renal arteries. And the reason is the low potassium in a host who is sort of a vascular path where you might be expecting this. So this is good. I'm going to finish just a minute or two over. Let me give you a few take-home messages. So remember that hypo and hypernatremia are almost always water imbalances. Volume depletion, as we clinically and classically think about it, stimulates the renin-angiotensin system. But it's the amount of water that determines the sodium concentration. Water depletion usually will stimulate ADH. So come back to thinking about these as the ratio of salt to water, with renin-aldo regulating the sodium and ADH regulating the osmolality. Remember that most of our potassium is intracellular. Really important to keep that in mind. A lot of shifting that takes place, and a variety of things affect our ability to excrete it, including our kidney function, anything that affects the renin-angiotensin-aldosterone pathway, and you need adequate urine output, which I didn't show you, distal delivery of sodium to excrete potassium. So I'll stop there, pretty close to on time, and I'll turn it back over to Dr. Singh.
Thanks, Brad. Just a couple of quick questions from the chat. First question is broadly related to how you treat hyponatremia with 3% hypertonic saline. Do you focus on the rate of correction, or do you focus on how much you correct over 24 hours, or both? And I think I know the answer, but perhaps you could answer.
Yeah, so you want to focus on both, and you can calculate the amount. There's 512 milliequivalents per liter of sodium in 3% saline. So you can calculate the sodium deficit, figure out how much 3% saline that is, and then administer it at a rate that will keep you within your goals for correction. You have to take into account ongoing losses, and you do need rapid turnaround times on your sodium levels, particularly for a symptomatic patient, so that you don't end up chasing your tail from overcorrecting.
And then the second question relatedly is, what's the role of sodium tablets in the treatment of hyponatremia?
So if you think about sodium tablets, it's really the ultimate hypertonic. Because it's pure sodium. And in SIADH, what we're trying to do is to increase solute excretion. So by giving some of that solute as sodium can be helpful, both in terms of increasing water excretion and providing sodium to help correct the deficit. It's a little hard to take. You need to take several grams 3 times a day. Some people are okay with it. It's usually used in combination with the loop diuretic in an SIADH patient to help lower the urine osmolality, which will make it more effective.
Great. And then last but not least, and there are a number of other questions, but I will try and cover some of them at least in the Q&A session. But this one, I think you are probably more qualified than anyone I know on this on our panel. Which of the following is a better reflection on urinary potassium wasting? Transtubular potassium gradient, spot urine potassium, or 24-hour urine potassium?
Well, so the best answer for the boards and in real life would be the 24-hour collection, not always convenient to get. Transtubular potassium gradients kind of fallen out of favor due to some of the assumptions that go into it. I mean, I'll still calculate it at times because it makes for some interesting teaching points. I've gotten more used to looking just at the urinary potassium on a random urine and either normalizing it to the creatinine, which you have to be careful of the units, or if you want to take a really simple approach, which is what I like, is that if most people take in 100 milliequivalents or so of potassium a day, if you look at a spot urine and multiply that by a normal urine volume, you can get a sense as to whether they're putting out what they're taking in or not. And that's really what you're looking for in terms of figuring out where the defect is.
Great, thank you. And I know you're going to be right back in about 30 minutes time. So thank you again for participating, and thanks everyone for asking questions.